I will give you a brief introduction to the history of surveillance, not because I think you don't know it, but rather because I know that surveillance is such an overloaded term that there's also microbiological surveillance cultures. So there's sometimes in the heads there's a mix of what surveillance we are referring to. So I'm just trying to make clear what I call surveillance and what school of surveillance I'm coming from. So this is basically the Langmuir statement from 1963. Surveillance is about systematic collection and evaluation of morbidity and mortality reports, and which the one that is even more important, in my opinion, is the regular dissemination to all who have contributed. Sometimes you do surveillance and then you know the numbers, you put them into a locker and don't do any feedback rounds, and that way it can't work, obviously. So the origin, it has long been applied to individuals. In 1963, Langmuir defined the term in a landmark paper in New England Journal. And then since 1970, the CDC established the NIST system. Nowadays, it's the NHSN, but at that time, it was the National Nosocomial Infection System. And the school I'm coming from is Henning Rüden, Peter Gastmeier, and they were actually friends with Theresa Horren from the who was a longtime leader in the NIST system. And this is also where I'm coming from. So the German KISS system is modeled closely after the NIST system, and the NIST system itself originates from this study that you are probably all aware of. This is the CINIC study. And for those of you who are not aware of this study, what they basically did is they assessed the nosocomial infection occurrence in 338 US hospitals, and then they implemented surveillance, and not only surveillance, but infection control. And after 5 years, they measured, and they obviously it was a controlled study, so it had two arms, and so surveillance and infection control in one arm, and no measures in the other arm. And then they assessed the occurrence of nosocomial infection again, and they had a decrease in the surveillance population and no change in the control arm. So this is like very long back. So I tell you, I'm born in 1975. So this was exactly when the CINIC study was finished. So maybe some of you who are older do know this from firsthand, but for me, it's like a history. It's been something I've been told because this happened before I was born. Okay, now a brief overview on what sepsis surveillance in maybe not only high-income countries is about, but when we started, you may be aware of the NEO-IPC project, which is also a Penta sponsored project, and I'm leading a work package there. And during that process, we did a review of surveillance systems and looked how many there are out there worldwide, and how they collect data, what kind of data they collect. And with respect to surveillance, we reviewed 19 national and supranational surveillance programs and analyzed their methods and their data they collect. And we found that regarding sepsis in neonates, 11 of the systems collected information on early onset, and also as many also collected on late onset sepsis. And we also looked on how many, because we had the focus of something that we will be discussing later on, or should probably be discussing on, the question whether clinical sepsis, so not lab-conformed sepsis, is included, because you are probably aware that this is an ongoing problem in neonates. For the reason that we collect so little blood that we have maybe a bad diagnostic sensitivity, and also for the reason that in some low and middle income settings you can't collect blood at all, so you only have clinical terms to define a sepsis or not. And so we were interested in how many of those systems have the entity clinical sepsis even defined, and we found out that there's 7 of them that had this. But the general problem that we had is that for most of the surveillance systems we reviewed, I will show you a slide after this one of the details. Many we couldn't access the protocols, the definitions. Some were only in scientific papers, but not the full protocol was available. And some systems also were no longer active or seemed inactive and didn't respond to inquiries from us. So the world of surveillance is quite complicated. Nevertheless, there is quite a few systems out there, and almost as many definitions also are out there. So there's national networks, there's supranational networks, there's at the bottom the European Point Prevalence Survey, which also collects information about infants. So there is actually a lot of systems, and most of them are really focused on high-income countries. So if you look at the countries of the national systems, you will see that there's a bias towards high-income countries. This can well be a search bias as well, so that we simply didn't know about the low and middle-income country surveillance systems that were out there, because A, we were bad at finding them, and B, because there was also maybe little public documentation on the internet or scientific publications around them, so that we could not find them. Now I'm putting the focus on the system that I'm most familiar with, because yeah, here's where I can tell you a lot of things, and that's NeoKISS. That's the German system. NeoKISS is a patient-based surveillance system. It focuses on newborns with a birth weight below 1,500 grams. We collect 3 entities: sepsis, pneumonia, and necrotizing enterocolitis, and also risk factors, antibiotic use, and multi-drug resistant pathogens. So not only infection, but also colonization with multi-drug resistant pathogens, which is something very specific in Germany. Maybe we will find time to discuss this later, but yeah, that's a specific thing in the German system. And now to the history, to the stages of development. So we did a pilot, and this is, as I told you, I joined the team here in the year 2000. So in 1994, 1995, Peter Gastmeier and Michael Opladen did a pilot in 1 NICU. Then they developed a method. They tested it in 3 NICUs in Berlin, actually. And then they expanded it and tested it in even more NICUs. And then they decided, oh, the method we initially developed is not perfect. It causes too much workload, and they switched again the method to the new system. And since the year 2000, this new system is in place, and so we are now in the 24th year of collecting neonatal sepsis data in the NeoKISS system. And yeah, this is the initial paper if you're interested in. So as you see, I'm not part of this. So at that time, I was not. I was already part of the team, but as a student, so I was not contributing to this paper in a scientific way. And if you look at the NeoKISS database now, we have more than 200 participating neonatology departments with more than 100,000 infants, more than 4 million patient days, 1 million central vascular catheter days, and 15,000 nosocomial sepsis. So this is a huge system. And you might ask yourself, well, how did they become so huge and so successful? So running it for 24 years is basically a matter of funding. We have been, as I said in the beginning, we have been funded by the Robert Koch Institute, so indirectly by the German government for more than 24 years now. So this way, it's it's not easy, but it's at least doable to maintain a system in a long run. So as you probably know, the funding is always less than you would wish, but if you have funding at all, that's good for keeping things running. And this is the case for us. And then there's also this part. So if you look here, in the beginning, we had to be very patient. So if you look at the year 2000, there were a few participating. I think it was 18 or so. And then it grew slowly and steadily. And I was, as I said, I joined the team here, and I was always discussing with Frank Schwab, who at that time maintained the database. Yeah, this is slowly growing and slowly growing. And at some point, there came the Federal Joint Committee on Quality Assurance measures, did a directive on quality assurance measures that basically came in effect on 1st of January 2006 and made the surveillance of hospital-acquired infections in neonates mandatory. So it's not really, yeah, it is more or less mandatory. At least a hospital can't get any funding for or reimbursement for the neonates they care for if they don't participate in a surveillance. So this is basically makes this mandatory. And this is also what happened after this. So we had a huge increase in participants. And this was actually the year I personally was involved as a student, or I did my last medical exam in 2005. So first year of being a doctor. So I was personally involved in developing the web data collection platform at that time, because this was an Access database and we had to switch to a web collection data platform because this was just too many participants to maintain this via email and anything like this. So another question or another part of the success story is also not only on the reference center side, but also on the participant side. So as you see, we have I've split it in two parts. We have neonatology staff, and this is mostly doctors who carry most of the burden, or this is an old, we did a survey on our participants on who does the actual work, and this is almost 10 years ago, so this may have changed, but last time we checked, it was mostly neonatology doctors doing the work, a small fraction of neonatology nurses, but also it's IPC staff, and it's really it is IPC nurses in Germany who do a lot of surveillance. In the NICU, it's actually a bit different because there's also NICU doctors involved in other, like the adult ICU setting, and so it's mostly infection control nurses doing the work. And in the NICU, at least they support a lot. So it's also almost 50%. Of the hospitals where infection control nurses do the work. And this is also some part of the success story. So surveillance is mandatory in Germany. So hospital managers have to ensure surveillance, and the health authorities can actually check whether surveillance happens, and the hospitals also have to ensure enough infection control staff to do the surveillance. So there's also calculation schemes on how many infection control nurses, how many infection control doctors you need per how many high-risk beds and the like. And we also have a established system with infection control nurses, infection control doctors, clinical link doctors, clinical link nurses, and this way, the surveillance runs very smoothly all of the time. So if in the Charité, I have an infection control nurse who does the surveillance twice a week, or sometimes even 3 times a week, collects data, goes to the ward. If we have any questions or uncertainties, I have my link doctors whom I can directly ask, to whom I have a personal contact for a long time, and so this works very, very smoothly. Now, just before the end, I wanted to show you a slide on how this developed over time. So this is the period from 2007 to 2023. And as you see, the sepsis goes down, and it's not only the clinical or cons sepsis, cons is coagulase negative staphylococci, but also sepsis with recognized pathogens that decreases over time. So in general, we also observe a improvement over time, and there's actually also, if you're interested, scientific papers published that show this effect for the sites that start participating, and even after 3 years, we still see a decrease in the sepsis rates when they participate. The last thing I want to talk about, because this is a project, this is my main focus at the moment, I would say, because the NeoKISS system is running and it's established and it's very well running, but it's also focused on Germany. And at some point we thought it might be helpful, because we're always wondering why it's working with us, and there are no national or supranational systems that are as big as we are aware, at least as we are, except for Jose will get introduced afterwards, who is collaborating with us with the NeoKISS ES system, which is the Spanish system, which is also quite huge, actually. But other than that, there's no really big system, and it would be a dream to collaborate even more and exchange data and think about what the differences are and why we have differences between different settings, countries, continents, income structures, whatever, and to improve together and learn from each other. And that's what the Neo-IPC surveillance system is for. So it's basically, it's in a way modeled after NeoKISS, but actually with Angela and also Jose, we had discussions, and we adopted the definitions a little bit to make them more feasible for low and middle income countries. And one of the things of being funded by the European Union is we also were able to develop quite a few tools and make them freely available. So the system is open for everybody to join. We have currently, so this is actually a snapshot I took yesterday. So the picture at the right and the numbers are really like absolutely fresh. So this is from yesterday. We had 12 departments participating from 4 countries, so Germany, Greece, South Africa, and Switzerland. And this is the development of the data this year. So you see a huge increase at the moment. So people are really starting to use this system, and it's growing really quickly. So in case you're interested, I've put in the link and also this QR code, which you can scan, and this takes you to the Neo-IPC surveillance website, where you find the resources and the methods. Some of you may already be aware, but in case you're not, you are welcome to just get in touch with me or the team and see how you can join this. And with this, I'm at the end, and I'm happy to take your questions.
I'm going to ask you a little bit on the technical side. What does it take to maintain this system of NeoKISS now with over 200 participating neonatal units? So from the central coordination side, and you mentioned a little bit about it needing to change the data entry from an access to a web-based collection. Could you expand on that, please?
Yes. Thank you, Angela. So there's basically, in maintaining the system, there's basically, we have it split into 2 halves. One is the technical part, and one is the more like epidemiological and clinical part. So there's 2 kinds of questions we typically get, and obviously also the technical part also involves like updating systems, keeping them up to date, developing new features, and so on. So we have quite a few IT resources. I think if I count correctly, we have 6 full-time IT specialists in our team. So this is quite a lot, given that we are a scientific institution and a medical institution. So who has 6 full-time IT specialists? This is also tied to the being the National Reference Center. They don't only do the surveillance in neonates, but also like the whole surveillance system is maintained by this team. And then there's the epidemiological and medical and clinical part. And this is typically we have one doctor. Now we have switched it to it being two doctor. Most of the time it's one senior person. So for the neonatal component, that's me. And we recently changed it to also include a junior partner into the team, and the junior partner gets mentored by the senior partner, but also helps maintaining the system and answering questions and the like. And that's, as you could guess, probably that's Gisem now for the NeoKISS system, because she did such a good job with the Neo IPC component. So we now do the NeoKISS system also together, and there's, I would say, with 200 participants, there's maybe a question or two a week that comes in regarding epidemiologic or technical things. So this is not a huge amount of workload. And the bigger part is the IT part, not because there's a lot of problems, but it needs constant maintenance and constant updating. And we also, if we want new features, we also need the IT team. So they are really busy doing this. So they also do the technical support, and this is even more than the medical and epidemiological support. So that's basically what it means to maintain. And I think we have, for the whole National Reference Center, we have about two and a half full-time equivalents, and we have more than 1,000 hospitals participating in the overall system. So it's quite huge.
Thank you, Brar. There's quite a flood of questions for you now in the chat. I'll try and combine some of them. So Jose asked you about the role of the clinical link doctors. And there was another question about what parameters do you enter per neonate? And do you include prophylaxis in the surveillance system?
Okay, so what is the role of the clinical link doctor? So Germany has kind of a special setup. As I said, we as infection control doctors are not clinicians. So we are like considered like a clinical theoretical part. That's how we call it. But we are not really treating patients. So we are only advising on infection control, on antibiotic stewardship, but we are not actively treating patients. And from this, this is a good position for me, because I'm never torn apart between like the duties on the ward and the epidemiologic part of this. So this is probably something that you can very well relate to, that you're always like, you need to spend time in the office and do things, but then there's patients to treat, which always comes first. And this doesn't happen in my setup, because I don't treat any patients. So I can spend all my time in the office and do these kinds of things, but we still go to the wards, and we need to go to the wards to interact, so rather for consulting and interaction with the team. And there we have the preferred partners. This is the link doctors. They get a training of 1 week, one full week of IPC and how it all works. So they're basically my link doctors on the NICU are basically neonatologists. They're senior neonatologists. One is Christoph Dahme, who's the deputy director of our NICU, or of our neonatology department, and they are my first contact point when it comes to exchanging clinical and epidemiological know-how. And if we do outbreak management or the like, that's us who does it together. Okay, right. Now the second question was
asking clinical parameters. What do you include? And we might stop there, because I want to give Christina a chance. So the last question.
Exactly.
And
also,
then maybe
it's too complicated, probably.
Yeah, no problem. But go ahead, and then Brar, I'll ask you if you wouldn't mind answering the other questions in the chat once Christina starts.
No problem. So the clinical parameters is as risk factors we include in the KISS system. We include central vascular catheters, peripheral vascular catheters, intubation, and also non-invasive ventilatory support. We collect information about antibiotics. And so there's little about prophylaxis, but I'm also not absolutely sure what you mean by prophylaxis. Do you mean antibiotic prophylaxis? In that case, yes, because we just collect whether a baby gets antibiotics. not the exact reason why this happens. So prophylaxis might be covered by this. Yeah, okay, and I will keep it with that and
thank you.
Answer the rest in the chat.
Thank you, Brar. We really appreciate that.
So I'll briefly talk about the burden of neonatal infections, or rather sepsis in low-resource settings, and then look at the role of surveillance in these settings, and then look at the surveillance platforms that exist in low-resource settings, such as Kenya, where I work, and also talk about related research that's been embedded within these platforms. And then I'll finish off by talking about the South Africa project. So sepsis is among the leading causes of neonatal deaths globally, and it's associated with poor outcomes, as shown here, if inadequately treated. Let me just put on my pointer. Yes. So one of the poor outcomes of these neurological impairments, which can be long-term and poses a huge burden to communities. And low-resource settings carry the highest burden of neonatal morbidity and mortality, as shown here. And the risk of dying in these settings is actually higher, about 11 times higher, and that's among babies who are in high-income settings. And therefore, we need urgent measures to end preventable deaths caused by sepsis in this region. And also improve survival of neonates in low-resource settings who continue to face regional disparities, as you can see, when accessing healthcare, and also disparities when it comes to their outcome. So when you look at the different studies that have been done in low-resource settings, particularly in the African continent, looking at neonatal sepsis, this is an example of one of these systematic review and meta-analysis that was done looking at the prevalence of hospital-acquired infections among hospitalized patients in Africa. So sepsis, as has been shown, is useful in characterizing the burden of infection, and also characterizing the burden of antimicrobial use and resistance, and colonization-resistant bacteria. Data collected through surveillance may be useful in optimizing treatment, benchmarking practice.
Sorry,
also,
would you mind
yes,
switching off your video? We're getting intermittent sound, please. Thanks.
So data collected through surveillance may be useful in optimizing treatment, benchmarking practice, and also improving the quality of care. However, in low-resource settings, we face many challenges that hinder routine surveillance, such as understaffing, and you also have the problem of having poor infrastructure and inadequate funds to conduct routine surveillance. And therefore, because of this, there are other ways in which we can adapt, we can use to easily, or rather, collect simple data to help inform decision making. And one of this is by conducting point prevalence surveys, which have been shown to be less expensive and easier to conduct as a way of collecting data. So this slide shows a recently published systematic review and meta-analysis of point prevalence surveys in Africa. And this study found a point prevalence of hospital-acquired infections, which was higher than what's reported in developed countries. So it was 13%, a point prevalence of 13%. And this was highest among patients who were admitted to intensive care units and on the neonatal wards. And then only about 40% of the healthcare associated infections that are reported documented a positive microbiological culture result, showing that most of these settings are not able to do blood cultures or even other cultures for the purposes of patient care. And from the culture results, the leading cause of infection was gram-negative bacteria. The other thing that was found was that there was an underrepresentation of studies, with few of the studies being conducted in the Central African region. And then there was a high heterogeneity in the methods and reporting that was done. Therefore, this affected generalizability of the results to other low-resource settings, and also underscores the need to have validated and context-specific surveillance protocols for this setting. So the highlighted study is the only one that was performed, including a neonatal population. And this shows that this vulnerable population is much underrepresented in studies done in low-resource settings, such as in the African continent. So another thing other data that can be derived from surveillance is how antibiotics are used for treating infections, such as neonatal sepsis. And this shows a systematic review of studies which are done, or this is a study that was done following the global point prevalence survey guidance in the African setting in 4 countries as shown here, looking at antimicrobial use, and reported a high prevalence of antimicrobial use of up to even 80% in Nigeria. And then looked at the indications for usage of antibiotics. The second leading indication was use of antibiotics for medical prophylaxis in babies who have risk factors for sepsis. So next we look at the considerations when designing and thinking of implementing surveillance, and this applies to all settings, but will highlight the challenges that we face in low-resource settings. So as already mentioned, surveillance studies can be complicated and resource-intensive to implement in settings such as ours, where we don't have validated surveillance protocols for conducting this kind of studies, and we also have very limited microbiology lab capacity. So here we see some of the key practical considerations when you want to design and implement surveillance for sepsis, for example, and this includes thinking about which case definition one would use when identifying the neonates would be included in the surveillance. So this is important as most low-resource settings are not able to do blood cultures, as I've already mentioned, on all babies, and therefore sepsis is mostly diagnosed on clinical suspicion. Therefore, one needs to think of which criteria will be used in identifying the babies who have sepsis. And an important thing to note is also that when you have a consensus definition of sepsis, which can be used across different settings, and it aids in comparing results that are derived from the research that's conducted. So another important consideration to think about is the neonates from whom the data and the samples will be collected, and then also which variables will be collected during the surveillance. And then the other thing also I'd like to highlight is that for surveillance, especially where invasive sampling is not done, usually poses minimal risk to the patients who are involved, and therefore a waiver of consent where possible may be beneficial in ensuring that data collection is complete. So next we look at different surveillance platforms and studies conducted in our setting, and that's in Kenya, highlighting some of the challenges and the results. So the KEMRI, Kenya Medical Research Institute Wellcome Trust research program where I work has over the years established surveillance platforms supporting clinical care and research in Kenyan hospitals. So one of these platforms is a clinical information network, and this was set up through partnership with the Ministry of Health and the Kenya Pediatric Association to support hospitals in improving documentation of neonatal and pediatric data. And with this network, different research studies have been embedded within the network, and also alongside clinical work. So an example of the research that has been embedded within the clinical information network is the Clinical Information Network Antimicrobial Resistance Project, that is CINAMAR. And this is a prospective surveillance for bacteremia and AMR in 12 hospitals linked to high quality microbiology laboratories, which are mostly located within research facilities. So it basically uses a hub and spoke approach such that samples are collected from these hospitals and then sent to the nearby research laboratories for analysis. So one of the things, some of the observations that have been made from this surveillance is that culture positivity rates have been quite low, about 3%, with high contamination rates, and they've also observed high proportions of patients presenting with antibiotic pretreatment, and or sampling for culture being done after initiation of antibiotics. So these are some of the challenges that we face when you're implementing surveillance in our setting. The results of this surveillance, the CNMR surveillance, are yet to be published. The other surveillance that's been conducted in our setting is the NeoBac surveillance, which investigated bacteremia and AMR by implementing systematic blood culture and environmental sampling for antibiotic susceptibility testing and sequencing at 3 public secondary level hospitals in Kenya. And this was done between 2020 and 2023. So analysis of data and samples is ongoing. So neonates who presented at the 3 hospitals, clinical sepsis, had blood culture done prior to initiation of IV antibiotics. And then those who were discharged home had the final follow-up on day 28 to document their outcome. So the study did establish microbiologic culture capacity for all neonatal admissions at Mbagathi Hospital and at Kiambu hospitals, which wasn't the case before the surveillance was started. And this essentially extended from the surveillance that was being conducted at the Kilifi County Hospital, which I'll talk about on the next slide after this. So before NeoBac started, blood cultures were barely done at Mbagathi and Kiambu hospitals for neonatal admissions. So the next surveillance platform I'll talk about is the one based the one based in Kilifi, which is, as I mentioned, a small rural coastal town along the Indian Ocean. And this is a Kilifi bacteremia surveillance platform that includes hospital-based surveillance for bacteremia at the Kilifi County Hospital. So this is a hospital, and it's embedded right in the Kilifi Health and Demographic Surveillance System. So we do surveillance for bacteremia here. And the platform has a rich repository of clinical and microbiological culture data and admission plasma samples since 1998. All admissions, including neonates, have a blood culture sample taken at admission, and then also this is done following a clinical deterioration. So a lot of funding has been essential to support this work over the years. And then admission data is linked to the Kilifi Health and Demographic Surveillance System, which conducts quarterly census. And this is the red part here, the red section here, and it's shown magnified here. So through the surveillance platform, we have been able to investigate population-based incidence estimates of bacteremia since 1998 and have assessed AMR phenotypes and genotypes by analyzing archived blood culture isolates in Kilifi. So this slide shows a snapshot of the point prevalence survey we participated in, and this was done within the NeoObs study. So NeoObs was a large prospective multi-site cohort study that investigated the causes, clinical signs, patterns of antibiotic use, and clinical outcomes of neonatal sepsis. And this was done between 2018 and 2020, and the results are published. So 3,204 infants aged less than 60 days were enrolled at 19 sites in 11 countries, which are predominantly low-resource countries. And this enrollment criteria was based on a set of clinical and laboratory science. And then during NeoObs, as I mentioned, we conducted a one-day point prevalence survey of infections, risk factors, and antibiotic use in the neonatal unit. So what we did, we collected unit level and anonymized patient level data on 2 separate days using standard CRFs, given examples of the kind of data that collected during the survey. And case definitions of sepsis included both culture positive and culture negative sepsis. And the latter definition, that's culture negative sepsis, was assigned to majority of the neonates who were on our ward in Kilifi, since most culture results were unavailable on the day of the survey. So I'll now discuss the SNP Africa surveillance, which we are currently setting up in 7 neonatal units in sub-Saharan Africa. So SNP Africa is a is an EDTCP-funded project that is responding to the urgent need for improved treatment of neonatal infections in the era of increasing antimicrobial resistance. And it comprises of partners from the global south and the global north, as shown here. And the project comprises of several work packages, including an adaptive antibiotic PK efficacy and safety trial for neonatal sepsis. And we also have work packages that are looking into stakeholder engagement and integration and training and capacity building of African researchers. And then we also do have the surveillance work package that's investigating neonatal sepsis and AMR. So we aim to establish capacity and methods to conduct surveillance of neonatal bloodstream infection, pathogen and antimicrobial susceptibility profiles, antimicrobial resistance burden and trends, colonization prevalence, and antibiotic prescribing patterns among neonates who are hospitalized in the 7 sub-Saharan African neonatal units. And while designing the protocol, surveillance protocol, you had to think through many aspects, and these are mainly have mostly been how to effectively implement surveillance in settings which have limited resources. So we are planning to conduct clinical and microbiological surveillance, so continuous data collection, so collecting data, clinical data, and routinely available clinical data, and also the results of blood and CSEP cultures where these are available continuously for about a period of 3 years. And then we'll also have quarterly point prevalence surveys done, where we'll collect antibiotic use data, and also alongside these collect fecal samples and surface swabs within the newborn unit. So we aim to collect a simple set of variables at 3 main time points, given that most of these units are low staffed, and we also are cognizant of funding that's available to support this work in these settings. So we are aiming to collect data at 3 main time points. That is when the units enter the surveillance, and then for the ones on the ward, in case of a deterioration, we collect clinical and microbiological data at that time point. And then the final time point for data collection is at exit from the surveillance. So that will be when they're discharged or when they die, for those who do not survive the illness. This will be, data collection will be done starting with a small population of babies within the newborn unit. For example, the areas where the high risk or critically ill babies are admitted to, for example, the NICU. And then over time, we'll expand activities to involve more babies or all the babies within the newborn unit based on available capacity to do that. And sites will be able to access key metrics derived from the data collected during the surveillance, for example, the number of admissions over a time period, and also blood culture positivity rates. And this can be useful in guiding patient care as we implement the surveillance protocol. We also plan to analyze surveillance data and develop models for outbreak detection, which may be useful in informing infection prevention measures within participating neonatal units. So the surveillance sites, so the units that are participating in SNP Africa surveillance have variable levels of clinical care and capacity, with only 2 having existing capacity for blood culture and blood culture on all neonates at admission, and also existing capacity to collect individual level patient data using electronic records at admission. And in addition to that, only 2 sites have the level of capacity extends to intensive care, while for the other 5 sites have low level high dependency care. So this we have very variable levels of care across the sites. And then also the annual neonatal admission ranges between about 1,000 units in Ghana and Tanzania to about 10,000 neonates admitted annually in Tanzania. So these sites vary a lot, and therefore in designing the protocol, you have to think about how can we conduct surveillance that can be easily and efficiently implemented across all the sites. So briefly in terms of methods, so I've talked about collecting clinical and microbiological data. So we have the general surveillance. What you'll do is babies will be screened when they are admitted to the neonatal unit, and those fulfilling the eligibility criteria will have data collected. Some babies may not. For example, if they don't have certain signs and symptoms of sepsis, which is one of the criteria that we are using for the surveillance, they may join the surveillance while on the ward. And the babies will continue the standard care of treatment while on the ward. So this is the first point of data collection, so at entry. And then if a baby deteriorates, they'll have data collected at this time point. And given that most of these sites do not perform cultures on all admissions or on babies who deteriorate as part of the septic screen, then the proxy marker for deterioration would be a repeat blood culture with where this is available, and then escalation of antibiotics to second line. Once a baby improves, then they will be discharged, and the final time point for data collection be at the point of exit. And the same would happen if the baby dies on the ward. So during the general surveillance, we will have a quarterly point prevalence survey where we'll collect stool or perianal swabs and antibiotic usage data from the babies who are on the unit at the time. So we are currently setting up the surveillance at the sites and plan to collect data and samples over about 3 years, following ethical approval of the protocol from all local ethics committees. And I think I'll make a presentation there, and I'd like to acknowledge the sites that are participating in the SNP Africa surveillance, and all the partners and funders and the funder. Thank you.
Great. Thank you so much, Christina, for that fantastic overview of the challenges and opportunities and the pressing need to do more surveillance in low resource setting neonatal units. I would like to move on to the panel discussion shortly, so I'm going to ask you just one question for now from the chat, and I will adapt it slightly. The question is around clinical surveillance. You clearly plan to incorporate that in the SNP Africa surveillance packages. Do you think, beyond the study, given that we haven't started yet, it will be feasible to continue clinical surveillance? Or do you think that bacteriological surveillance for bloodstream infections is perhaps the low-hanging fruit for African neonatal units that do have access to blood cultures?
Yeah, thanks, Angela, for that very interesting and important question. So I think it's important to acknowledge the capacities that African settings have in terms of diagnosis of infection and also patient care, and the need to be able to utilize data. And so as much as I feel like as much as having cultures and centering surveillance around microbiological cultures for in terms of getting data collection and designing the protocol, I think that clinical surveillance is important, and we would need to have more studies done to look at which clinical information is useful and key in defining what sepsis is in our settings, and also predicting sepsis outcomes. And even before that, which clinical data is helpful in screening babies who come to the newborn unit and identifying those at risk and thereby maybe needing targeted antimicrobial therapy for improved survival. So combining both clinical and microbiological surveillance is good, but most of the settings, such as ours, are not able to have cultures available, don't have cultures available at all times, and therefore clinical surveillance would be helpful in making decisions for settings such as ours. Yeah.
Thank you, Christina. I'm going to invite the rest of our panelists and Brar to join just by switching your videos on. And I think if we can go from there talking about blood cultures, I'm going to come first to our microbiologist at Stellenbosch University, Prof. Andrew Whitelaw. Andrew, when you start, please just introduce yourself a little bit more. But my questions for you are along the lines of how can we do better, given that so many hospitals in Africa still lack access to high quality diagnostic microbiology services. And even when those services are available, there's now data to show that they're not being used by neonatal units to send blood cultures and diagnose sepsis. Thanks, Andrew.
So thanks, Angela, and certainly thanks to Penta for the invitation to be part of the panel. Angela, thank you so much for throwing me in the deep end with the probably most challenging question. I'm a clinical microbiologist based at the NHLS laboratories at Tygerberg Hospital and Department of Medical Microbiology at Stellenbosch University. So, yeah, I think everyone's aware that one of the big challenges in Africa and I think low resource settings globally is that access to laboratory services is limited and very often of variable quality as well. And yeah, the question of how do you improve things it's obviously difficult. Otherwise, we would have done it by now. I mean, the standard answer is resources and political will, and I think that needs to be part of it. If you don't have a laboratory service at all, you need to start somewhere, and you need lab infrastructure to be set up, and that needs to be supported through funding mechanisms and also, I suppose, programs to ensure that it's sustainable. Christina highlighted it, the fact that a lot of the microbiological research is being driven through research agencies and donor funding, which is fantastic. I think that the concern that many people have is that once the research is finished, do you get a sustainable service, or do people pack up and go, and then you've got a bit of a white elephant laboratory? I think a big part of it is also actually advocacy around the need for microbiological services, and partly for surveillance, but I think also partly for clinical patient management. And this comes down to demonstrating that if you have got culture facilities available, that the laboratories can offer a clinically useful service that is going to impact on patient management. And this probably comes down to education and training of clinicians who are sending the samples, as well as the lab staff who are processing it. One of the big challenges in neonatal sepsis in particular is that the culture positivity rates are usually quite low. So you can understand there's a perception that, why do I send a blood culture when there's a 95% chance that it'll be negative? It doesn't mean the child doesn't have sepsis. It means probably they put too little blood in the bottle, or there was a delay getting the bottle to the laboratory, or whatever. So, for a 5% yield, and then you get a few coagulase negative staph thrown in to complicate your life, where's the value? So what we probably also need to do for at least microbiology services is possibly piggyback on adult infection, where your positivity rates are generally higher. And if you can get a laboratory service functioning for the hospital as a whole, then neonatal services are obviously going to be using it as well as the adult services. So it's not purely a neonatal service delivery issue. But yeah, I think advocacy around both probably the clinical benefit to start with, because that's likely to drive clinicians more than necessarily a surveillance IPC initiative. But I think that's just the reality. Ensuring that you've got a sustainable service, you can offer a reasonably clinically relevant turnaround time. And then using models, as Christina said, if you've got one reference laboratory, try hub and spoke models. The concern then is your logistics need to be very jacked up. Otherwise, you encounter delays and your results are not clinically valuable. And then advocacy through either global donors or through local ministries of health, or whoever, around setting up the laboratory services and ensuring they're sustainable. You probably need to start small and then expand. Don't try and do it all at once. Those are kind of some random thoughts, but it's a very challenging issue because we haven't solved it yet. I mean, the other discussion is around alternatives to microbiology services. So rapid point of care tests, some of the point of care kind of molecular assays, those might be alternatives, and that's a kind of a discussion on its own.
Great, thank you, Andrew. That's a very holistic answer to a difficult question. I'm going to encourage Christina and Brar also maybe to type some answers to Gareth and Robin in the chat so long, because my next question is for Jose. Jose, do you mind putting on your video, please? Jose is our collaborator on the Neo-IPC program, but also is leading a really successful Neo-KISSes program in Spain. And introduce yourself a little bit when you start, Jose. But my question to you is, when you started off the Neo-KISS ES program, what were some of the barriers and facilitators to implementation that you encountered? How did you overcome them? And how are you sustaining the program? Thanks.
Good afternoon, everyone. Thank you very much, Angela, for your kind invitation, and to the Penta cooperative group for assisting to attending such an interesting aperitivo session. Okay, I would introduce myself briefly. I am a medical doctor, recently retired, but still alive, teaching.
Busy.
Was training in telemedicine, but I did some clinical epidemiology training additionally. Okay, and I participated in one of the old neonatal networks that Brar showed one of his slides, the Neonatal. It's dead, it's not active. And afterwards, I just started participating in the Spanish version of Neo-KISS system. Okay, Professor Mas, who was the leader of our unit in our hospital, in the neonatal unit, he was involved in a lot of international research, and he met Brar and other people at Charité, and he was quite quickly aware of the importance of having a specific neonatal surveillance system. So, because these German people, they did all the hard work at the beginning. They validated all the process in these pilot studies. We just took advantage of it, and we started the Spanish version, which is now running in about 55 neonatal units. And well, we are just focused on sepsis, and we even share some data with the German system, which is in a kind of binational benchmarking, which is very interesting. Just trying to answer your question, the Spanish version of Neo-KISS has been working in based of research funding, which is good, but it's not, because we are always having the problem, risking the problem of lacking funding to keep this system active. So sustainability is always a problem. We don't have the political will that has made this big system in Germany. We have a very important moral nominal support from our government, but we don't receive any funding or material sustainment for the system. So That creates always a problem. And the surveillance system is always working according to the amount of research funding that we have at the moment. When we started, indeed, we had the leader, we had this professor, and we had a lot of people, a lot of neonatal staff in a lot of Spanish units very aware of the problem of neonatal sepsis. I think I've never read it, but if we were talking of surveillance in terms of cost effectiveness, probably, specifically neonatal sepsis, surveillance with the reduction in sepsis figures would probably be one of the most cost-effective activities in terms of the healthcare service. Okay, that's it. For me, is an important point. We had in the good side. We had the enthusiasm of a lot of people who were willing to participate, were willing to know what their figures were, how well or bad they were doing, and were eager to compare the data and try to see how things could be done better. Challenges, so many, sorry, with time, money, definitions of sepsis were problem at the beginning, but with the NeoKISS system, it was much easier. A lot of changes in staff. We have a very high turnover of personnel, so keeping active, stable infection control teams, local teams at the units, I mean, neonatal nurses and neonatal doctors, is always difficult because there is a lot of people leaving and coming. Training people also takes time and effort. So this is a problem, high turnover. Cleanliness, I would say, you have to keep always working and working and working, trying to keep things, to do it better. Sometimes things go well. Sometimes there is a break, there is a bad time, and things go down, and your figures go high. So sustainability, not always from the point of view of having resources, but also from keeping the enthusiasm and the willingness of people I think it's always for me, for our project, I think it's a challenge. So we also have problems with our regulations. You know that Europe is a very high area of regulation, a lot of rules, a lot of laws, and the data protection European law is creating some problems in order to go forward in some aspects. I think that would be the main important challenges. But on the other hand, surveillance system provides you with such useful information. You know where you are. You know how you are doing. You know that your effort to improve things are going well. Your figures are better, or maybe they are not doing well. But you can compare with some other sites. And this is very important. Benchmarking is that you have, as Brar said at the beginning, you have to end the cycle. You have to communicate and disseminate all this information. So that would be, in my humble opinion, one of the main important points according to our Spanish experience.
Thank you so much, Jose. That's very insightful, and I think a good roadmap for Christina and I and the other African sites as we start with surveillance in SNP Africa. So maybe that's a question that I'll put to Christina based on what Jose said. What are the plans, given that SNP Africa is a research consortium, to actually share the surveillance data with the sites so that it is information for action, so that it's actually used on the neonatal units that are contributing the data? Christina?
Thank you, Angela, for that question. So in South Africa, what we plan to do is we'll collect data both on paper case report forms, and then that will be transferred onto an electronic database with potential to move to direct electronic data capture as we implement the protocol. And one of the things that you're designing now, besides the database, is a dashboard which we'll use during the surveillance to display to sites. So each site will have access to the dashboard, and this will have summaries of key metrics derived from the data that you collect at each site. And what the sites will be able to do is see this data, see the summaries, and as we conduct the surveillance, will it will be possible for sites to utilize the information that's available to them to inform clinical decision making. So that's one of the things that we hope to happen during the surveillance. And then as we collect data, we also plan to analyze it such that we can be able to, one of the objectives is to derive alert thresholds for outbreak detection within the newborn unit. And if we're able to do this, then that can inform implementation of infection prevention and control measures in a timely manner if one is able to detect outbreaks early before they become a big problem within the newborn units.
Thank you, Christina. I think that's probably one of the most important functions of real-time surveillance in African neonatal units, is to be an early warning system before outbreaks become massive and entrenched and endemic. So we really look forward to that dashboard. Thanks, Christina. So the last question in our last 2 minutes before Penta breaking news is the question to Brar. And Brar, it's a more policy sort of global impact question around what is the role of global organizations or regional organizations like the World Health Organization, ECDC, Africa CDC, in supporting and enabling countries and institutions to do neonatal infection surveillance. In 2 minutes, please.
Yeah, so probably we should talk about what should be the role, because there is little role, as we probably know they currently take, especially they do in surveillance in general, but especially when it comes to neonatal surveillance, there's very little happening. So the ECDC does the point prevalence survey, but this is very, very limited with regard to the information you can draw out of this for neonatal infection. So, and there's nothing else going on in Europe from the European CDC. And as far as I know, also the WHO has no dedicated surveillance system or the like for neonates. So the question is not what is their role, but rather I would say what should their role be. And obviously there should be a role, so they should be taking this a little bit more serious. And I have been lobbying at ECDC for a long time. This was before the European financial crisis, so already more than 10 or 15 years ago. And at that point, they were almost agreeing that this is important, but then it fell off the topic list because they had to consolidate and did not add any new methods at that point. But I think we should still follow up. And I think the problem is, and I said this earlier today, I think the problem is that this gets underestimated all the time. Yeah. So you think about this being a very, especially if you look from the European perspective, we have like shrinking populations. So like 1-2 children per family maybe, and a very tiny fraction of those are very preterm infants. So you see this as a very tiny population. And if you look at this globally, not all the countries are shrinking. You know, we have exploding populations in some countries and have huge amount of newborns in some settings. And from a global perspective, like if you have a like severe damage to a newborn, the lifelong consequences on a personal but also on a financial and political level are devastating. So, and I think this typically gets underestimated, and that's why everybody says, yes, we should do something about the babies, but then like there's so many priorities and this gets put aside. And that's why I kind of accept that it's probably us, the stakeholders, who really have a personal, like scientific or like activism interest taking this over, and still not stop lobbying those institutions, but because it is their job, or it should be. But on the other hand, we can't wait for them to just do the things we need. I think in a way we also have to just do it ourselves and maybe ask them for help later or see how we can interact, but not wait for them at least.
Thank you, Brar, for that important message. Don't wait. Sign up today for a neonatal infection surveillance program near you. Good luck to everybody embarking on this really important but not an easy task. And thank you especially to our speakers and panelists today for an interactive and insightful discussion.